So we have finished so far in psychiatric diseases. We have finished depression, that is we call it as affective diseases or affective disorders. Then we have finished bipolar. Then again one component of it was a schizoaffective. Then we have gone for schizophrenia, and now we shall move for other which are their example of these are various panic disorders and or anxiety disorders and insomnia related treatment. Now before that, let us go for diagnostic measures. Even in schizophrenia I told you, but let us repeat it, or let us make just a brief revision what we have seen for schizophrenia. What are various tests or scales as we have seen. So these scales are there as they are given in DPRO. I will be advising you to search for the better or more test, because DPRO whatsoever we are using, it is quite old. Maybe fortunately or unfortunately, there are no big changes have so far occurred after last 8-10 years. No big changes are there, but it is always good, because as such we have seen the recent guidelines only. We have went for the latest guideline which are available on various sites. Instead of a book, I tried from that, but the scales are which are compared, which are available at one place, so we are using the book reference for this. So for schizophrenia, what are various rating scales? Example of this is first one is brief psychiatric rating scale, that is BPRS. It is done by clinicians, so we call it as a clinician rated. Now you'll see the difference, very big difference. In the bottom places you can find that in depression there are many scales which are there, either which are done by patient itself, that is patient rated, may it be Big Depression Inventory or Zung Self Rating Depression or Patient Health Questionnaire PHQ-9, which is very common. These are actually patient rated, that means patient can also do it. And some are like Hamilton 1 or Montgomery, these are clinician 1. But very important thing that here we have various scales which are only clinician rated, because the severity and the conditions where it will be very impossible to trust or put the faith in the patient itself that whatsoever information he is putting is correct, and therefore we have to see that the clinician is taking it. The scorings are around 18 items are there. 7-point severity scale is there, that is from mildly ill, that is having minimum score of 32. Moderately ill is having a score of 44. Then markedly ill is having score of 55, and severely ill which is having 70 when correlated to this control one. Then or when we compare it to the another one more study is there, that is CGI, that is clinical global impression study. So when we correlate it with this, then we can have a better judgment. So this BPRS provides a description of each severity rating to increase the reliability in that. It has 4 clusters of the symptoms. One is thinking disturbances, then anxious depression, withdrawal retardation, and hostility or suspiciousness. So on this all we can say 4 important aspects of schizophrenia this scale will be doing assessment. Then second is positive and negative syndrome scale, that is PANSS. It is also clinician rated. All these are clinician rated already, I told you. It is a 30 item scale, 7-point severity scale. Mildly ill will have a score of 57, moderately ill will have 75, markedly ill will have 95, and severely ill will have 116. And again it has to be compared or correlated with this clinical global impression scale. This is giving the information. So this is based on this 18 atom BPRS, the previous one, for assessing the presence or absence of positive and negative symptoms and psychopathology of a schizophrenia. It will be guiding on that. Then next is a clinical global impression, that is CGI scale. We can have varieties of it, that is CGI severity of illness scale, CGI I scale, that is global improvement. Global means here not global, global here it means overall, because there are several aspects we see. So the improvement is not in one aspect. We have seen four aspects, example in previous scale BPRS, that is the thinking disturbances, four cluster of major symptom we have seen, that is thinking disturbances, anxious depression, withdrawal, and hostility, suspiciousness. So these are four clusters are there. So global means which is involving four cluster, all clusters, that is global one. Okay. Then CGIS means severity of illness, global improvement, and CGI is only CGI is efficacy index. So these are three again sub scales of this CGI. What it is doing? It is doing the severity of illness and global improvement on 7-point rating scales. So global here always we have to keep in mind it is overall improvement. Okay. It is not like global warming, that is warming of earth. So here the global meaning is not global. At many times this global word is used in our biological science, that is whole when we consider. So this global improvement on the 7-point scales, efficacy index 1:4, 1 to 4, marked improvement 5 to 8, moderate is 9 to 12, minimal is there, and 13 to 16 is unchanged. I hope you can now correlate it. If you remember, we have seen the guidelines using various drugs. If you remember that we have seen that we are using one drug, particularly we are selecting any one drug, and while using one drug, what we have seen that we will check for how many days? Around 2 to 4 weeks. After 2 to 4 weeks, if we do not see any improvement, now where we will see improvement? This is the global impression scale, or clinical global impression scale will give us that whether there is a efficacy or not. If there is a efficacy, good efficacy, there is a mark index, a mark improvement is there, then okay, there is no need for increase in the dose or change in the drug. Moderate is there, yes, we can try to continue, and if it is we are satisfied that goal is slowly we are reaching towards goal, we will be happy about it. But if it is minimal or it is worse condition, then definitely we have to either increase the drug or increase the dose. And if still it is not working, then we have seen that we are giving for clonazepine. If you remember, I am just revising it fast. We will go for clonazepine, and if it is clonazepine resistant, then we are going for electroconvulsive therapy. If you remember all this, so this is how these guidelines are taking help of this various rating scale or diagnostic tools. This is observational and non-symptom specific for assessing three global subsets. One is severity of illness, then global improvement and efficacy index measurement for both therapeutic and side effects. Now again, if you remember side effects, we have got various parameters. If you remember, we have seen that what is body weight is happening, what is ECG changes are occurring, what are the liver function tests are occurring, and we have seen that at what interval we have to conduct it. Example, we have seen if it is olanzapine, then we have to check body weight or BMI, body mass index in repeated fashion, or the frequency is more comparatively. If it is other drug, then okay, we will check it other things. So we will check diabetes, we will check various factors. So what is the thing? Because we do not want that we are trying to cure patient from schizophrenia, and then we are putting patient for suffering with some other which is very what we can say dangerous disease or dangerous problem. So simultaneously we are trying to manage both. So this is how these various schizophrenia scales are there. Even we have used few names in our previous class. The various scales are there. So all these scales we are using, and accordingly we are going for the judgment. The next topic we shall be going for various anxiety or panic disorders. Now, just a minute. Just Then what are various scales for anxiety rating? So again, just like depression, we have got Hamilton scale, that is, it was Hamilton depression scale. Here it is Hamilton anxiety scale. We call it as a HAM A or HAM AS or HAM IRS, RS, sorry. So these are various conditions which are used, scales. So this is again clinician rated, that is, it is done by clinician. It has got 14 items. It is a 5-point scale. Its score of greater than 18 to 20, they indicate moderate anxiety. It has got it has got some subscales to measure somatic and psychic anxiety. क्लास है बेटा, नंतर आपण डिस्कस करू. क्लास चालू आहे माझा. बरं, एक दोन नाही दाखव 2 मिनिटात. त्याच्यात लिहून टाक. इट मे बी any oral any which will involve formulation of sublingual or any such kind of formulation. लिहून टाक, फायनल करून टाकलं, which will involve. So next in that, the another scale is self-rating anxiety scale. It can be done by patient, that is known as that is by Zung SAS, that is self-rating anxiety scale. It is patient rated. It is 20 item scales. There are 4-point intensity ratings. It correlates to the clinician rated anxiety status inventory. That is what your clinician has done. Accordingly, it is matched with that, and there is a little information on the validity of either test. Means it is not sure how much validity is. Use of sublingual or mouth releasing formulation. Releasing the spelling. फायनल करून सेंड करून टाक. चल, ओके. है ना, सीसी मला पाठव. So this will be there is a little information on the validity of this test, because all these tests has to be made valid. So this until and unless they are valid, however still they are widely used, but validity means what happens is, if you remember, we have seen or we discussed many a time about evidence based medicines. So in medicines it is very, very important to have feedback outputs from that, and if these tests are there, if it is widely used, then everywhere, suppose if there is one patient X, and if this scale is introduced to the patient to Aurangabad, then what's your result we have got? If again patient goes to maybe Pune after few days without any treatment, or without expecting that there is no increase or decrease in that, so there should be constant score. But if it is not constant, then that means that becomes a qualitative type of score, and it doesn't make a quantitative one, because that amount, that the score level is changing, and particularly if it is a borderline, then it becomes very difficult for that. So these are validated. Most of these are validated, and if these are validated, then it means that it will show almost similar results, or the results are exact, they are very trustworthy. So this is the difficulty with that. Then next is Sheehan panic and anticipatory anxiety scale. That is, we call it as it can be done by a patient or clinician rated. It is a 3-part scale. It measures panic attacks, anticipatory anxiety, and limited symptom attacks. It is doing it. Then next is the Yale Brown obsessive compulsive scale. Now this is one more topic which we have in our syllabus. It is somewhere between sort of depression, sort of anxiety. That is called as a obsessive compulsive scale or obsessive compulsive disorder. It is clinician rated. It has got a semi-structured interview. It consists of several cluster of obsessions and compulsions. It is used to assess baseline severity and change in the treatment studies in accordingly. So these are various conditions. These all we are going to encounter. For sleep, we don't have any scale. When person and the relative says that they did not have enough sleep, then we have to trust, and accordingly we should go for the treatment. So then what's your next topics which are there? These are, one is anxiety, or we call them as a panic disorders. Second thing is what we call it as a obsessive compulsive disorders, and third thing is there, that is sleep or insomnia. So we can these are various scales, or these are various diagnostic tools for that particular conditions. So after we get this understanding that the patient is having difficulty in as anxiety or maybe obsessive compulsive disorder or sleep is, for that we don't have rating as I told you, then we can go for treatment. I hope for that in most of the cases the treatment is same. I'll suggest you to go for or go through the treatment. For this example, for sleep we have drugs, we call them as a hypnotics and sedatives. Can anybody tell me the difference between hypnotic sedatives and other depressants? Yes, anybody? And what about sedatives? Okay. Okay, sedative calms the subject without inducing sleep. Okay, it is dose dependent response. Okay, fine, very good. So basically, very commonly it is called as hypnotics are the drugs which resembles natural sleep. Okay, these are the agents which resembles or which produce the sleep or which can induce the sleep which is resembling to the natural sleep, while the agents like sedatives, as many have written it, they decrease the activity, or they causes drowsiness, or they causes the calming of the substance. So they are also central nervous system depressants, and they causes the what we can say, they reduce, briefly we can say, they reduce the obstruction or they reduce the barrier between person while going to sleep. They make it closer to sleep, but they do not resemble the natural sleep. As hypnotics resemble natural sleep, they do not resemble it, but they carry the person, or they take the condition towards sleep they assist, they help into, so when the problem is smaller one, when only because of this kind of obstructions, maybe mental obstruction, thinking obstruction, or such kind of obstructions are there, they are sedative are just trying to overcome this obstruction so that patient can itself go into natural sleep. uh, we say that it is dose dependent, but not always, because it depends. If you understand the concepts of potency and efficacy, then it will be clear to you. When we say that it is a dose dependent, then we are you are talking that it is a potency wise, that is, or when you give it in small doses, and it is doing like sedative. If we are going in higher doses, it is working like hypnotic, but not always, because one more thing is there to what we call as efficacy. uh, there are some abilities, we call it the intrinsic activity of drug. So if there are drugs which do not have that intrinsic activity, then even if you give it in high doses, they will not able to elicit that particular action. Okay, example, let me tell you, in benzodiazepine class, the drugs like alprazolam cannot become hypnotic. Okay, and because, or it cannot be a dose dependent, because alprazolam can only acting as a anti-anxiety drug, or it has got best effect as anti-anxiety. It can cause some sedation, but it cannot be hypnotic. I hope you understand. So it may not be always dose dependent. In some cases it may be, but not in all cases. This is, I am just clarifying. Okay, let me know about various drugs which you have studied as a sedatives or hypnotics. Anybody remembers the classification? Rima, it is not classification. You have just told me one name. Yes, barbiturates, benzodiazepine. Then apart from this, Pratima, you are going for totally different classes of drug. When we are discussing, we are yes, barbiturate, benzodiazepines, they are there. Apart from that, okay. Now, can you name? Can you give me the mechanism of action of this barbiturate benzodiazepine? Classification of it. Okay, you just post this on the group that what are the mechanism of this action of this, and what are various drugs which are there as a sedatives and hypnotics. Okay, okay. Now let us go for considerations of it, how we are going to use these sedatives and hypnotics. Uh, Now, what is the usual sleep one person requires? How much sleep is expected that one person should have every day? One hour, 2 hour? What is minimum sleep required? 7 to 8 hours. Pooja ko ke 8 hours. Pratima says 6 to 7 hour. Okay. Yes, minimum 6 hours study. People say that, or scientists say that it should be minimum 6 hours. Okay, what will happen if person do not sleep? Why we need to make the person sleep? It's good if he is not sleeping, isn't it? He will study more if the person if the person is from, suppose, your class, 4th year Form D. So definitely the person will utilize his time in study things more, isn't it? More productivity. Why we want person to sleep? Why we want, or why we call it as a disease? We call it, if the person is not having enough sleep, what we call, what kind of disease it is? Insomnia. Very good. So why we consider insomnia as a disease? Why don't we consider it as a benefit? It's good that we are not sleeping, or the person is not sleeping. Can others are working, or they are productive only for maybe 15 hours, 16 hours. The person is productive for more than that. So why don't we take it as a good sign? What is the problem in this? Yes, it causes decreases alertness, it causes decrease in the activity. Very good. Then thinking issues means, yes, clarity, decrease in immunity. Okay, decrease in focus. Very good. Then can't make decision. Okay, by the way, does anybody know what happens during sleep, or why sleep is beneficial? Suppose I lie on the bed, I am giving rest to the body, but I don't want to sleep. I will watch movie, I will read book, I will talk, but I am lying on bed, Mansi. So my body will be resting. So is it not enough? So if I am giving rest to my body, I hope it has done my job. Yes or no? Then what is the problem? Why we want it? Okay. By the way, rest to brain. Okay. By the way, do you know sleep patterns? No? Okay. Again, this is one more homework. Please put it in group for those who are not attending or not present. There are various sleep patterns. We call it, okay, and these patterns are detected using instruments or what we can say graphs. We call it as EEG, that is electroencephalogram. Have you ever heard about EEGs, electroencephalogram? Okay. So electroencephalograms shows various signs, and we have got types of sleep. We call them, there are basically two important categories or phases, we call it as a, one is called as a REM sleep, that is rapid eye movement sleep, and second we call it as a NREM sleep, that is non-rapid eye movement sleep. Okay. So one is superficial sleep, other is deep sleep. Now is anybody can recall from this clue? What happens during this sleep process, during REM sleep or NREM sleeps? Tomorrow you can put this on group in brief, at least everybody please read it, that what is sleep, what are various types of sleep, REM sleep, NREM sleep, okay, what are the what we can say activities which are happening, or what job brain is doing during sleep. Okay, you will happy to know that brain is working during sleep also. Actually there is no rest that way, but only thing is we are not giving the sensory inputs to brain. Actually what injury was there, Pratima? Was there any injury there? For what kind of healing, what kind of repair it is doing? Do you feel that there was some injury? And because when we say that we are giving rest to brain, and then you say that it is for healing and repair, then what kind of exactly it is? Why there should be internal damage? Why there should be bleeding? Okay, forget. Okay, it's going, off track. Let us bring it to track. Let us make it fast. So please go through that. What are various, and I'll suggest you to read good books, maybe Guyton or Tortora, like that. What are various sleep patterns? What is the physiology of sleep? Which are the neurotransmitters which are involved in the sleep? See, this is your physiology homework. First is what? First homework is what? Go through the physiology of sleep. What do you mean? What is sleep? What happens during sleep? What I told you, the patterns, that is REM and NREM. What happens during REM sleep? What happens during NREM sleep? Okay, why it is important? What activity is actually happening during sleep? Now, once we understand that what brain is doing during sleep, as I told you, brain is not actually resting that way. We may call it as a rest because yes, some of the stimuli which brain is constantly receiving, some of these are not going. Example, while sleeping, we don't have any kind of visual stimuli, we don't have auditory stimuli, we may not have to give some responses which are expected. I am asking you question. Definitely those who are sleeping now, those who are enjoying their afternoon sleep after their lunch, so they are not getting my questions, isn't it? So definitely they will not be able to reply. So that way they are happy, their brain is working, isn't it? for other activities except this. So this stimuli which others are getting, this is stimulus. When I am asking you question, you are hearing it, it is auditory stimuli. Then this auditory stimuli is going to appropriate place in your brain. From that brain we call them as association neurons. This association neuron is getting it to your that memory portion, and you are trying to answer it. Okay, then you are understanding it. So those who are answering it, they should be very sure that yes, this whole process is going good in their brain. That is what they can hear what I am speaking. They can, the whatsoever hearing is there, they have got a cognitive domain. They are understanding that yes, whatsoever teacher is speaking, it is something question. So that is a cognition. That is what we call as a cognition domain. It is going to cognition domain. From cognition domain, it going to association domain, because it is, if it is a question, then you should answer it. You are trying to answer it. Okay. So this is this third one thing which is very positively people are doing. Maybe answer is wrong. That doesn't matter. But you should be happy that then others, at least you are able to do this much better, isn't it? Those who are either not hearing, and this all thing cannot happen during sleep, isn't it? If somebody asks you what's your easiest question, what is your name, you will not answer, because what is happening, your auditory stimuli, they are minimal, only at very high frequency. बहुत जोर से कोई चिल्लाएगा उठ क्या सो रहा है करके, देन है ना. अभी अगर मैं जोर से चिल्लाऊँ तो जो सो रहे हैं they will definitely get up, yes sir, isn't it? So this will happen. This is at higher stimuli. Otherwise the threshold, we call it as, isn't it? Threshold has been changed. So only at very high frequency, very high, this one they will get up. Otherwise this auditory stimuli not going, no visual stimuli जो तुम लोग देख रहे हो, they will not able to see. So these whole stimuli, whatsoever stimuli are there, they are not reaching. So this type of activities are reduced. But it doesn't mean that brain is not working, or it doesn't mean that brain is taking rest. So what exactly brain is doing, that I want to know. Tomorrow definitely by this evening or by tomorrow morning, I am expecting what is happening. I want to know that what brain is doing during sleep. Just like heart does not stop working during sleep, okay, throughout the life. We know that if heart stop means everything stop. Similarly, brain doesn't stop working. That has to be kept in mind. Okay. Again, mind is linked with the brain. Whatsoever things come into mind, these are all related to brain. We have seen all this. We have seen this all anti-psychotic agent or depression, because their mind was involved. The mind was not doing what it should have done. Okay, thinking absurd, thinking of maybe depression is a sort of suicidal thought or negative thought. This is mind. And this psychiatric, when we study, it is related to psych means mind. So we have something we have discussed about mind. Now what we want to know, that how this is happening, what is happening, because again mind and thinking is a neurotransmitter. Okay, so if somebody's mind is doing this, somebody's mind is doing that, everywhere what is involved is a neurotransmitter. So brain is that way very interesting, very complex to understand, because there are even very tiny areas, but they are very powerful in doing many things. Example, if we know, we call it as a basal ganglia, we call it as a limbic system. They are comparatively very small areas, but they are responsible for various emotions and various feelings. So this everything is very important, and sleep plays very, very important role in each and everything. So what is the function of sleep? What sleep do for us? What is the optimal sleep is required, and what should be the quality of sleep? As I told you, REM, NREM. What kind of sleep is required, and then what is the benefit of it? And then next is, in that only you will realize, or you will understand. Once you understand that what sleep is doing for you, then you will definitely go for it, and you will understand that what will happen if the sleep is deprived. Okay, this is again very good this information you will have, that what will happen if the sleep is deprived. and then we can understand what are the consequences of insomnia, that what are the consequences of insomnia. Then next homework is you have got is you have studied pharmacology, you have studied CNS in second year, please, and I am very happy to know that everybody has passed all the subjects of second year, since you are already there in fourth year. So not only second year, but you have already passed third year also almost, and therefore since you are there in fourth year, so you must be having the knowledge what you have studied in second year pharmacology, that drugs acting on CNS, like those which are acting as a hypnotics and sedatives. So I'll like to know a brief about it. What are various drugs classification wise, which are the drugs which are there, which classes are there, either chemical or pharmacological classification, how they act, and what are various drugs in that. Okay, if it is we have seen just two, many of you have put into two drugs, barbiturates and benzodiazepine. Apart from that, there are also many drugs. Okay, now one more homework. So two homework so far. One is physiology and pathophysiology related to sleep is one thing. Second thing, we want the drugs which are you have studied in pharmacology as hypnotic sedative. And third thing, what we want to know is what are various classes of various in these drugs, what are classes, example subclasses, example barbiturates, what are these, various barbiturates, various benzodiazepine or any other drugs, and how these drugs are effective, how these drugs are active. So these are various agents, how these drugs should be. एक 5-7 मिनट में क्लास में. So these are how these drugs are there, these drugs are active, and what are their pros and cons. Okay, please go through it. We have got 1 day gap in between. I'll ask again, though, if somebody has not submitted or put into group. Then important thing is, suppose if it is barbiturate, then what are the problems with the barbiturate? Have you ever encountered the word that is called as a drug automatism? Drug automatism, or very good. Anyone have got the thing that is called as a barbiturate poisoning? Have you ever encountered this barbiturate poisoning? Okay, Mansi, can you tell me how it happens, barbiturate poisoning, in what condition? If writing is a problem, you can speak, no problem, because if it is lengthy one, you can definitely speak it out totally.
Sir, excess dose of barbiturates.
Okay, why there should be excess dose of barbiturate?
In some cases, if the patient accidentally overdoses
Okay,
himself.
okay, okay. Apart from that accidental, is there any chance? Okay, that is what drug automatism, which is very interesting, and that's why I suggest, this is why I used to ask today. I deliberately, I just stopped, and I wanted to have this, what is the basic you are having, and I am surprised to know many things should have been there. Anyway, what happens with the barbiturate is, you know the word tolerance, everybody?
Yes, sir.
What is tolerance?
Minimum level which we can tolerate, or maximum level which we can tolerate of a drug.
Very good, very good. Is there any second opinion to this? Anybody wants that to modify it little bit? It is correct. When I started asking question from 22, it has become 19 now. It's gradually running away people, isn't it? So I think Mansi has got a very strong grip on the class. Good CR, isn't it? Nobody wants to differ. Mansi,
Yes,
everybody
sir.
accept you. No one wants to change Mansi's statement. No one thinks that she is not correct. Let us change it. Yes. Okay. So that means you are not read the or you are not remembering the basic in pharmacology. Basically, tolerance word is not for how much one can tolerate. It is it is
Sir, after that we can't take, means the drug doesn't show effect after that limit.
yes. That is what tolerance is. It's different then. It's not related to your or how much you can tolerate or not. You may tolerate even 10 times of it. It may not
Yes,
show
sir.
any adverse effect after that. Okay. Suppose
Yes,
the
sir.
dose was 10 milligram and we are giving 100 milligram, so almost 10 time or maybe 1000 milligram, but and it may or may not show adverse effect. We are keeping it aside now. It is not relevant because it is not how much I can tolerate. I can tolerate 1000 gram. Okay, when the dose was 10 milligram, I can tolerate 1000 gram. But for what purpose I was giving 10 milligram, that purpose is not being served. The purpose is, suppose it was hypnotic drug, that 10 milligram was given to me, it was prescribed to me for what purpose? So that it should induce the sleep, isn't it? Now in that 10 milligram, I will not get sleep, I will not get in 20 milligram, I will not get in 30 milligram. So that means the tolerance is developed for that particularly hypnotic action. You understood this? Everybody understood what is tolerance?
Sir, if we increase the dose, then the effect is not seen.
Yes, effect is
Is it?
not seen or it is less than what is normally seen.
Okay, sir.
Okay, this is what? This is what?
Tolerance.
Tolerance. One more term is there which is synonymous to tolerance. What it is?
Uh,
Tachyphylaxis.
yes, sir.
Tolerance is slow, tachyphylaxis is fast. Immediately in second, third dose, it can happen is a tachyphylaxis. After around few months of treatment, it is happening, then it is a tolerance. Understood difference?
Yes, sir.
Fine. Now, what funny thing is there with funny means rather it's serious with barbiturate is barbiturate has got many effects, and the effect which we want is our effect. The effect we do not want are the side effects or adverse effects which are not acceptable. I hope you understand. This is very simplest way I am telling. Okay. So barbiturate has got many effects. Out of that, the important effect is it should cause CNS depression through what's your mechanism of action, which you all are going to put it by tomorrow. Now, in that, it can cause respiratory depression. It can cause uh, impact on the or depression on the CNS. So, what it can cause, particularly in elder patients, is it can cause amnesia. What is amnesia?
Memory loss.
Memory loss. Very good. So, those who are not answering, I am sure they don't have amnesia. Amnesia is a very dangerous one. We shall see it when we shall see Alzheimer's. Okay. So, amnesia is there. It can cause amnesia. Again, memory, we have got type short term memory and long term memory. So, slowly it's starts affecting short term and then it goes to long term. Now, what will happen is it will develop tolerance to this. Which one? Sedate hypnotic effect. So patient has taken 10 milligram tablet, particularly this insomnia is more common in the elderly people. So this elderly people, the person is elderly patient, has taken barbiturate. He was taking barbiturate every day, every evening. Now got 10 milligram dose, but the tolerance is developed. That means he will not get the hypnotic effect. But tolerance is not developed to other effect, which is amnesia. Tolerance is not developed to the respiratory depression. So what the person will have, do that after 8, suppose in the evening 8 p.m. the person takes tablet, he feels sleepy at 9:30. Now he is not feeling sleepy. Why he is not feeling sleepy? Because tolerance is developed. And then after some time he will say that most probably I may not have taken tablet. He will take another tablet. Okay. Why he is taking another tablet? Because effect is not there, and second thing is he forgot whether the person has taken tablet or not. So this type of cyclic activity, what is cyclic activity? He is taking additional dose, and still the effect is decreased. This type of thing is called as a drug automatism. So you read it, you will I have given you the basics. You will read it, you will find it interesting, and this is the major cause of adverse effect. Barbiturates can be definitely used as a for even suicidal or homicidal purposes. People take it deliberately, multiple tablets. But this is one of the reason. Automaticity is where it is neither accidental nor it is because of the effect of the drug. Actually, it is the impact of the drug which is dangerous. If it is homicidal, you can try to keep the person, because homicidal means, example, person who are having depression or any other such cases, they can go for that. These are the suicidal tendencies. Homicidal means someone is putting in some others maybe food and in high doses, we call it as a homicidal. Okay, and this is because of the adverse effect of the drug. So these are the problems with drug. Please read pharmacokinetics of each drug well. Can anybody recall what is the half-life of benzodiazepine, that is diazepam? So read pharmacokinetics well, read the pharmacology of all the drugs well, put it there, okay, briefly, and post it. If you wish, the best thing is you put it on classroom, sort of table, maybe in Excel, or you can put it on WhatsApp also, no problem. So please put it there, and let me understand that what your basics say about physiology of sleep, types of sleep, functions during sleep, various agents. One more thing I wanted to ask you, or you put emphasis on, is role of melatonin. Have you ever heard about melatonin?
Yes, sir.
What it is?
Sleep inducing hormone.
Very good.
Sir, it is.
Very good. Very good. Excellent. Because many students get confused between melanin and melatonin. So it is a sleep inducing hormone. Very good. Fine. Okay. And what role it is playing? So I'll suggest, see, I have given quite exhaustive work. If you wish, you can divide it about what is about melatonin. Somebody can search and write what melatonin is and what it is doing, what are the action it is, effect it is having. Okay, what is its important? It's very interesting to know about melatonin. And then what about pharmacology of drugs, and what about the physiology and pathophysiology of sleep. So please go through this. You put this on group one by one, and this will definitely put our basis clear for our because in pharmacotherapeutics, basically what we are doing, already we have discussed it earlier. What exactly we are doing here is, we know what are the drugs which are available. because in pharmacology we know we have got the list, we have got their pharmacokinetics, we have got their pharmacodynamics, we have got their adverse reactions, their indications, special conditions. Now we are selecting what is the best in given condition. Okay, so for that we should be knowing what is the situation, and in what way we are using it. So just go through it, then we shall the sleep in that sedative hypnotics. As such, number of drugs are very less in therapeutics. Very few drugs will be using it, which are drug of first choice and second choice, like that. So it won't make a big difference into it. We can do it very fast, but these basics will definitely help you to understand why they can be first line treatment, or why others can be second line treatment. I hope this will means this will be done by tomorrow evening. Then you please do it, read it thoroughly, and then put it on group. Okay, and if you have any difficulties, you can definitely ask at any time. You can put it on group only, what's your difficulty, whosoever is facing. Okay, take care, be safe, and just go through the things which I have advised you.